Okay, it looks like we are live. Welcome everyone. This is Adrienne with Yoga for Migraine, and I'm super excited to welcome Dr. Lauren Natbony to the Yoga for Migraine community today. She was an amazing presenter at the 2023 Migraine World Summit, and after her talk, I was just so excited to hear what she had to say. It was just a breath of fresh air, and really her approach aligned so much with the way I work with my Beyond Migraine coaching clients. So welcome, Dr. Natbony. Thank you so much for your time today.
Thank you so much for having me. I feel like I'm so honored to be here and to be able to talk to everyone who's on.
Wonderful. Well, I'm gonna check. Yeah, okay, we are live. I see people on. Good. And we got so many great questions. I don't know if we'll have time for all of them, but we'll at least get ones that were submitted. And if folks have comments or questions as we go, feel free to drop them in the chat. Before I give my formal introduction of Dr. Natbony, just a heads up, enrollment in my Beyond Migraine coaching program ends May 8th. So we've got a couple more weeks to get in. And I also am offering a big sale if you're able to join on a single or double payment plan. We integrate yoga for migraine, pain reprocessing therapy, and daily self-care habits, many of which Dr. Natbony discussed in her talk, and probably we will talk more on today. So I'll put the link for you guys to check that out to learn more about Beyond Migraine. And let's welcome Dr. Natbony formally and share. She's a board-certified neurologist and fellowship-trained headache specialist, and the founder and medical director of the Integrative Headache Medicine of New York. She created and authored this book that sounds fantastic, the Integrative Headache Medicine, an evidence-based guide for clinicians. She's also a mother, an acupuncture and lifestyle medicine expert, and someone who herself experiences migraine and headache. And her practice really focuses on empowering patients with integrative healing tools by creating individualized holistic treatment plans. When I read about what she did, this was just sounded like the ideal scenario for people to get help with migraine. So it's like so exciting to hear about what you do. And just to kick off, I'd love to hear your experience, personal experience about living with migraine.
It's a journey. I have to start off by saying it's a journey. I'll just say my experience with migraine started as a child when my mom, I remember finding her in the shower, just literally like slumped against the shower wall, holding her head, crying, vomiting, like the shower. I'd have to actually like literally lift her sometimes and put her in the shower because it was that pressure of the water, the combination heat cold therapy that would help her. And she refused to take anything, like refused to treat, like was that I'm fine, everything's fine, which is what I inherited too. So that really stuck with me as I got older. Obviously, a woman getting older, started having a lot of car sickness, a lot of motion sickness. And that's really how it started for me. And still to this day, I can't go anywhere unless I'm driving. And then the light sensitivity, sound sensitivity, I was always like, oh, just like turn it down. Like my sister, if you ask anyone, she'd be like, stop telling me to be quiet. I'm like, no, it's just my ears, I'm just more sensitive. And then obviously the pain part. And I remember being in medical school and curling up in a ball in a fetal position on the floor and just crying and being like, just let this be over. So for me personally, like it was really challenging going through training and having to deal with migraine. And everyone has their own experiences they deal with, but when you have to sort of be on point all the time and take in information and learn, it's really challenging. So for me personally, my experience is I remember being on an airplane and I remember reading a magazine about how all these celebrities like changed their life. They started doing all these things, like they started exercising and eating well. And I'm like, light bulb goes off. And I'm like, I have to make a change. And I don't know, everyone has their light bulb moment, right? But from that moment, I actually decided to start exercising. And for me personally, exercise saved me because it gave me something that I hated to become something that I loved and something that gave me my mental peace. And from there, I felt like other things started to fall into place. As I was exercising more, my sleep got better. I started focusing more on putting good food into my body, and sort of the snowball effect of one thing led to another and led me to where I am. now obviously not only being a headache doctor, but also being able to better manage myself and my mom and friends and family. Long story, but that's kind of
I see that, right, from childhood and then experiencing it yourself. And did that personal experience lead you to study like headache medicine, or was that kind of just something you always knew you wanted to do?
So to be honest, I didn't know there was a thing as headache medicine growing up. And I still think a lot of people don't know that there are headache specialists. I knew that I was interested in the brain. I always wanted to either be a neurologist, a psychiatrist, something to do with the brain. And I was fascinated about the effects of pain disorders and of the, I don't know if I love the term invisible illness. It's not invisible, but it's things like we can't see, but are so debilitating. So that was always what I wanted to do. And then I realized there was headache. Actually, I did in medical school, I went away to some electives in headache centers and realized that that was what I wanted to do. So I entered residency and I went to a great program where I had a great headache program. And I feel like that really fostered my love for it, but it was always something that was in my mind.
Yeah.
It just really blossomed over time.
That's exciting to hear, right? That you kind of followed this inkling of wanting to work with the brain and to, very specialized, which it's crazy. It's so specialized given how many people live with migraine. And so tell me about, what it means to you to be, work with an integrative approach. Is that unusual among physicians who work with headache and migraine? Is that becoming more accepted?
So that's a really great question, because I feel like integrative in a lot of senses, people think it's not evidence-based, that it's basically this alternative. Not alternative. It is just as mainstream as any pharmaceutical treatment. I actually think that our medical system has been limited by time. So it takes more time to actually talk about different integrative approaches, like the impacts of sleep, the impacts of exercise, of stress, of all of these different components. It takes more time to discuss than just to prescribe a pill and say, here's a pill, here you go. And we're also not really taught that stuff in medical school. Like we're taught a lot about like pathophysiology, how things work, and then how you treat them with medicine. But not saying that there are tools that are medicine. I love medicine. Medicine is great, but there are other tools out there, and that actually treating a person from multiple vantage points actually covers a lot more and gets them better than one thing alone. So I don't think it's unique to me. I think people think about it. I just haven't found many practitioners who practice it and practice it effectively.
Yeah, that's good to hear. I mean, I felt like, especially this year at the Migraine World Summit, it is happening more and more where neurologists are sharing more alternative approaches that don't just include, pharmacological treatments, and that seems like it's kind of becoming more accepted over time. But yeah, I was curious from your end as a physician if you see that happening.
I also think there's a lack of education. Like yoga actually has evidence, like biofeedback has evidence, exercise has evidence. There are clinical trials. But I think when we think about it, we're thinking, or when doctors think about it, it's just not the go-to. So I kind of want to get away from the word alternative and say, these are part of the treatment program. It is a toolbox of treatments. This is a mainstream. This is what should be prescribed. It should be part of a prescription, maybe not sent to a pharmacy, but part of everyone's treatment plan.
Love that. Love that. Well, let's dive into some of the questions people submitted. And Tom had a great question that he emailed. So if someone's got 30 to 60 minutes a day, and you're going to kind of divide it up into some of these lifestyle practices, like how would you divide it between perhaps mindfulness, yoga, exercise? Is there a one size fits all recommendation for that? How would you answer that?
Definitely not a one size fits all. I was actually thinking about this. And I could tell you, like, evidence-based versus the way I do it versus the ideal way. So I feel like the best evidence has been for cardiovascular exercise, but for those who can't, or they need more gentle exercise, yoga does have data. And the evidence for mindfulness and meditation doesn't really compare itself to the physical activity, but is more of an add-on. That being said, mindfulness can take place at any time. So yoga, when you're doing yoga, can incorporate mindfulness. For me, if I'm running, I'm incorporating mindfulness. I actually listen to basically for runners, mindfulness. So you can put that on at the same time, and basically finding what you enjoy, because if you find something that you enjoy, that's something that you're going to stick with. So in a 30-minute time, I would say find an activity that you can do and then actually disconnect from everything during that activity. So if you're going to pick yoga, don't be at yoga and be on your phone and be thinking about a million things. It's basically being present in the moment with whatever you do, I think is the best tool, because there's not one right or one wrong answer. It's more utilizing the time that you have.
Right. Yeah. So you can,
But
yeah, you can, right. Like you said, make it something you enjoy. That's going to be the easiest thing to keep up. And I know that is a thing, especially for folks who have trouble exercise. How much do you think it's important to kind of keep that consistency? I think that's a hang up too. That is hard for people to do anything 30 minutes a day consistently sometimes, when perhaps like running, for example. So is it important to have something that can be done more consistently? Does that make a difference?
absolutely. I think consistency is important, but everyone, for example, I didn't exercise for 2 weeks. Like I was really busy. I didn't do it, but forgiving yourself and saying there's always going to be times where I can't be consistent. And that's okay. We have a whole year. If for the majority of the time you're consistent, great. And I also think 30 minutes is a big commitment. So what I would say is, okay, my range, I'm going to do anywhere between 10 to 30 minutes. And give yourself some leeway, saying, yes, on the days I have time for 30 minutes, I'll do 30 minutes. But if I do 10 minutes, great. Like, it's still something. I think getting away from that all or nothing mindset, either I do 30 minutes or I do nothing, is what the problem is. So even if it's 5 minutes, even literally, I get up sometimes, like I've been sitting at my desk for 8 hours. I get up and I do some yoga stretches. And I'm like, well, I didn't do anything else today, but at least I got up and I did some yoga stretches and yoga poses. And that is better than I would have done if I didn't do anything. Yes, so yes, consistency, but also forgiving yourself and just doing what you can do.
Yes, I think my Beyond Migraine clients will hear your voice in mind. Like, yeah, I totally work with folks. That mindset of all or nothing can be an obstacle, because especially for many people with chronic pain, like perfectionism tends to be an issue. And like, we want to get it all right, and then, do the max, or perhaps do something that we used to do. And we used to be able to run a marathon, right? And then with migraine, things change, and getting to that place where even just a little bit is helping. It's helping you feel better. It doesn't have to be all or nothing. I think that's such an important message.
And I think also in terms of combining things, so I actually, something called SPOGA. So it's spinning and yoga. So I love combining actually like cycling and yoga, because actually like high intensity interval training has good evidence for migraine. So like little spurts of activities. So I don't know, I kind of made this myself, but I find it very effective, is I will do short flows of yoga and then go and get my heart rate up just for a few minutes, just on the bike, and then go back and forth. Even for a short period of time, it's low impact and it's easy. And I have found that to be good when you're like, I don't know which one to do. It kind of gives you a little bit of both.
That's great. Yeah, starting to combine some of these things. Yeah. Sarah O had a really very creative question. If you could create a camp for people, summer camp for people with migraine, what would an ideal day look like in terms of activities, periods of rest? Let's dream up a summer camp for migraine.
I love that question. I was like, I need to create a summer camp.
Like, I know, me too. I was like, maybe we need
that's the next thing that has to happen, a retreat, something.
Yes, that has been in the back of my mind for a while too.
So especially for patients, when they like want to take a break from things, I'm always saying that we should create a schedule, create a routine. So I think the first thing that's important in a camp is, when summer camp as a kid, there's always schedule. There's the bell. You do things at certain times of the day. And we do know that routine and consistency is important. So I would set a schedule of, we're going to get the optimal hours of sleep a night, which is for most people like 7 to 8. Let's start with the morning. We wake up in the morning. We eat something nutritious with protein within 30 to 60 minutes. We actually sit and mindfully eat, not just eat and run out the door. We make sure that we have 8 ounces of water just to hydrate our bodies first thing in the morning. I would say to make sure we're exposing ourselves to sunlight first thing in the morning, because it's important for our natural circadian rhythm. And then getting outdoors, some fresh air, and basically stimulating the senses. Yes, I know it can be hard to do that in the morning, but really just trying to wake things up more naturally. So I think that's a good time, even for like 2 minutes, like walk outside and just like take a few deep breaths. And then basically structuring the day. What I would say is education. I would love a summer camp where I would say, starting with, what are the few things you think are a factor in migraine for you, because it's different for everyone. And then basically addressing those. So for some people, it is, I think stress it is a big factor, but what does that mean? And then really delving into what does stress mean and how do we actually alleviate stress, and sort of having workshops. Obviously that's not an ideal day, but I would love to have some workshops. And every day I'd probably do a mindfulness in the morning. I'd probably structure exercise in the morning. So that way we are not putting it too close to bedtime, and also making sure we have our energy stores up. I'd make sure we're eating a snack in the morning, having lunch, again, mindfulness while we're eating. I would say get some acupuncture in the afternoon.
A little massage, yeah.
Some acupuncture, some yoga, and then really group. I would want to have group, basically talking about what I think great ideas come from other people. And I think that's where support groups are really important. But I think at a summer camp, having all the available migraine products out there and actually being able to try them, because I think a lot of times there are things that we don't even know work for us. So I would say if we're having an afternoon like fair of just different migraine ice hats, different green light therapies, different weighted blankets, like different just stuff to just try. Also, there would be green lights everywhere. So that would be the only lighting. And I know that's like a really bad day because we go through the day, but I would be saying having dinner at a scheduled time, making sure that we're turning electronics off at least like an hour to two before bed, having a relaxing nighttime ritual. So whether it's taking a bath, taking a shower, drinking a warm liquid, reading a book, which I know is old school, actually flipping through a book, and having a wind down, something that winds your brain down at the end of the night, and then repeating that every day at the same schedule.
Sounds lovely. And for those of you, if you've heard of Retreat Migraine that Champ puts on, some of these things are part of that. And I know they're coming up, I think it's May 5th. They're doing their annual Retreat Migraine. So I'll just put a plug in for them. I've taught yoga with them for the last couple of years, but won't be able to do it this year. But yeah, they've got that similar like fair of devices and things you can try and lots of education. So there's something out there along those lines. But yeah, I love all those suggestions. It's something else we can brainstorm and maybe create real life.
I've read about it, but I've never, that sounds like great experience. So
yeah, it is an amazing community of, right, like you said, getting people together, learning from others and not feeling so alone. Let's chat about Car's question. For so many folks, and this is kind of a few people ask something similar, like for people who don't feel like they have an effective acute medication, triptans don't work. Carl is in the UK, like there's a lot more limits. Some of the drugs haven't even arrived there yet, like CGRP medications. How do people without an effective acute medication cope? What are your suggestions?
I was actually thinking about this a lot because that's a really good question. And I think being in the US, where obviously we have access to all of these medications, makes it easier to create a toolbox. But I think that triptans, much as we want to say there are so many people that they don't work for, I think the first thing to talk about in an acute treatment is method of delivery, because the medication can only work if you're delivering it into the body correctly for that person. So a lot of times, are you nauseous? Are you having any GI symptoms? At that point, I would say, okay, I would go non-oral route, because an oral medication probably isn't going to be effective. And saying, okay, for medication, what's available in my area that is nasal spray. Actually, you can compound a lot. I don't know about UK, but I compound a lot of nasal sprays that combine different ingredients that have evidence into a nasal spray for patients who don't tolerate oral. Same thing with rectal suppositories. I know that might not be a very popular method. There are medications that come in injectables. So I think for saying, okay, if you're nauseous, vomiting doesn't work, let's go a non-oral route. For those who don't have nausea or vomiting, it might be that the medication either isn't being absorbed or you're just not targeting the right receptors. I think we always think, okay, a medication has to work. It's for migraine. Triptans only target serotonin receptor. Like that is their mechanism of action.
Right.
I mean, there's other end stages it does, but there are so many receptors. Maybe we need to broaden our receptor profile. And that's where I like to layer on therapy. So even if a triptan is a little bit effective, we can augment it by adding an NSAID. We can augment it by adding a device at the same time. We can augment it by sitting in front of a green light. I put it as like the toolbox of it's maybe not one thing, but it's a combination of things. So depending on where you are, putting together a list of what is available in your area, and then talking about with your doctor or resources, how we're actually targeting different pieces of the puzzle at the same time. And there are actually rescue medications that you wouldn't think that would work, that do for some people. That, I mean, I'm totally evidence-based, but I also go on experience. I have combined a lot of different supplements. For example, boswellia. I love boswellia, and have found that that is a really great supplement to use for rescue. I'll combine it with magnesium. I'll combine it with some other either with or without pharmaceuticals, combine it with wearables. I love wearable devices. But I think that just because a triptan doesn't work, or just because one treatment or even 5 or 10 treatments don't work, I mean, that's usually the patients I see, nothing works. There has to be something that will work. We just haven't found it. And you need someone to really go down that road of exploring what is available and how we can put things together. So I had a patient today who told me that nothing worked in isolation. And finally today she said, things are finally working. You were right. It's the things in combination. It's not the one thing, it's doing them together. And I think we lose sight of that, thinking that one thing should work all the time.
Yeah, and I think that was such an important message you shared at the Migraine World Summit, that we got to do, it's not just the medication. We got to add these integrative approaches and maybe multiple medications, and we layer it until it kind of reaches that threshold where we can get some relief. So yeah. So don't lose hope, folks. I know.
Yeah, for that person with a question, and hopefully, obviously, the triptans will come at some point. But they're also, but they're not everything. I mean, we're targeting one receptor, and I feel like I wish I could go to that patient and say, let me help you find something. But there are other things out there. So have to search and find them, and never give up, because there is something, just haven't uncovered it yet.
Yeah, and that it might be a bunch of things at the same time, right? So that's a really good message. We got a few questions about vestibular migraine, of just what you found with your patients that have been most effective, and also people have asked, why do so few doctors really know about vestibular migraine? So I don't know if there's any of that you can touch on.
Vestibular migraine is kind of this basket of, because it's not an official ICHG, it's not in our official diagnostic criteria, it's in the appendix. And also everything that there can't be found a reason for, and people are dizzy, it's vestibular migraine. And I think there's a huge stigma that goes with it. When there are diagnostic criteria, you have to have a history of migraine in order to have vestibular migraine. So you have to have certain components to the dizziness, and for some reason it gets lost on so many doctors. I would say, like vestibular migraine it's also challenging to treat, because the medications that we're using for migraine should technically help with the vestibular symptoms, but there are some different ones and different things that we need to try, things that might aggravate vestibular symptoms that might not for someone without them. So I think the first thing is to know that patients have dizziness and vestibular symptoms with migraine. I would say it's definitely underdiagnosed, underrecognized. And as being a person who's gets dizzy, nausea, it is so terrible. I completely empathize, because yes, I'm just going to say yes. But looking at the different treatments for it, the way I approach it is I say, okay, what are your, obviously we want to treat everything, but we can't always target everything at once. So the pain process, the vestibular process, I always try to overlap, but pick preventative pharmaceutical therapy that first has evidence for migraine, but also has some better evidence for vestibular migraine. But there are some treatments out there that work better for vestibular symptoms, but not for the pain. So that's, again, where the layering comes in. And then in the right patient, doing vestibular rehab, but appropriate vestibular rehab, not just sending to some, because it can make some patients worse. So we really have to be careful about what we're doing there. And this is where devices also come in. The Cephally and the GammaCore both have evidence for vestibular migraine. So I definitely like to use those. And I really look at I look obviously at all the different pieces, but vestibular migraine can be treated effectively. It's just, again, finding what works for that person. There's also an entity called triple PD. I don't know if you're familiar with it. Postural, perceptual, always forget the third P, dizziness. And there's an overlap there. And I think it's a very difficult thing for doctors to tease out of what's vestibular migraine, what's triple PD, what we do, because it's a subjective symptom, right? But again, going to a doctor who's knowledgeable on vestibular treatment, on vestibular migraine, should hopefully be able to diagnose and treat appropriately.
Yeah. And do you find a lot of the lifestyle strategies also work to help folks with vestibular migraine?
Absolutely. I tend to be more mindful and careful about different types of exercise because the vestibular system
Right.
be disrupted much more easily. So I will never want to do things that are really doing a lot of head motion and disrupting someone's position in space. I also worry more about falling. I also just tend to, if someone, for example, medication wise gets dizzy sitting to standing, which positional dizziness is a part of vestibular migraine, I wouldn't want to exacerbate that by, for example, giving them something that's going to drop their blood pressure. So they're also getting dizzy standing. So it's just, again, like looking at what the patient's symptoms are and then treating appropriately. But lifestyle, 100%, like all for it when it comes to vestibular migraine too.
Yeah. So I got a couple questions, got a few comments. I guess our live stream is kind of going in and out apparently, but looks like we're still good. I hope everybody, let me know if it's not good. We got some questions, just about like the long-term effects of having migraine, especially if someone doesn't find an effective treatment, like are strokes an issue, like are there long-term ramifications for people dealing with migraine, especially perhaps if they don't find a treatment that helps?
So short answer, no, like it sucks.
Yeah.
But migraine is not going to shorten your lifespan. It is not going to, the migraine disease process itself, it's not going to cause stroke or heart attack, but the stress that it imposes can not create those, but definitely contribute to other illnesses. But even if you don't find an effective treatment, it doesn't change your life expectancy. It just makes morbidity, which is basically the quality of your life, not as great. But I also think it's also looking at what is an effective and like a positive outcome. So there might be some people who we treat, but we're not getting rid of symptoms, but we're managing them appropriately. And that is enough to decrease the stress response. It's enough to sort of modulate things so the person can function and live a quality life. And that is a meaningful improvement. So just as a sidebar, just also looking for what our goals and targets are. But even if you never find something that takes pain away, there's no worry that I'm going to shorten your lifespan. The only caveat, again, it's not shortening lifespan, is migraine with aura just has a slightly higher risk of stroke. And we always counsel, if you have aura, again, risk is small, but always to modify any other risk factors, cardiovascular risk factors, like no smoking, making sure that you're checking to make sure your blood pressures are appropriate, making sure that you're treating any high cholesterol. And for women, just making sure you're checking in with your OB and talking about any estrogen containing compounds. Again, that's more, it's a longer discussion. But
yeah, it's not, migraine is not going to progress to some other disease or disorder. Yeah.
No. So yes, it is not going to alter or create another disease process or shorten the course of your life from the disease itself.
Good. That's the load off. All right, folks. And I'm seeing, thank you guys for posting questions in the chat. So I see them. Thank you. And it sounds like if folks are having trouble with the live stream, watching this on your phone is seeming to be a better quality for some reason. So I've got a couple more on my list, and then I hope to get to some of the ones that were posted. So hang in there, everyone. So one thing that I've heard on the Migraine World Summit, and my own neurologist has told me, and I'd love to get your feedback. Of course, most people with migraine fear medication overuse with triptans or NSAIDs. When triptans or NSAIDs are used in a more concentrated, perhaps 1 week dose. Maybe it's menstrual migraine, maybe someone's going on a trip, or does that create as much of a risk for medication overuse as perhaps if it's, those triptans spread out over a month?
I think that's one of the biggest misnomers of medication overuse headache. It doesn't happen in a vacuum. It doesn't happen in a short period of time. If you actually look at data, most patients who develop medication overuse headache have had migraine for about 10 years and have been overusing a medication for anywhere from 1 to 5 years before the medication overuse develops. It's different for different classes of medication, but let's say you're going in for a surgery and you need to take a medication for another process. A few weeks of taking a medication does not cause medication overuse headache. Medication overuse headache has to be at least 3 months of consistent medication overuse to even meet diagnostic criteria. But I think what people fear is that it's going to get worse. And yes, sure, you can take something and then you're not taking it and you feel the effects of not taking it, but it's not technically medication overuse headache. It's just like if I went out and I drank a ton of alcohol, like I feel the effects of not having alcohol or something similar to that.
Sure.
It's not actually changing your brain chemistry and propelling you, because medication overuse headache increases migraine frequency over time. That's why we want to avoid it. But short-term higher use of medication doesn't. That being said, if someone has menstrual migraine and is, let's say, going to use triptans a week out of the month, we do want to be mindful that, yes, we have our 10-day a month limit, 10-day a month limit for all rescue treatment. Not that, so 10 days, sort of looking at studies was where the average came out to be. Not saying that if you do 11 days, it's going to be the end of the world. It's an average. So some months you might do a little more, some you do a little bit less, but just being mindful that that's an average. You would have to do more than that consistently in order for that to become a problem. And that's also where multimodal therapy comes in, because medication overuse headache happens with certain medications and each medication has a different threshold. So something like, for example, there are combination medications that you can use less that might cause overuse, whereas things like simple non-steroidal anti-inflammatories, you might be able to use a little bit more. But that's where I like to add in, okay, not just because you have 10 days a month to use your triptan, that's where you add in your G-Pand, because there really is no risk of medication overuse there. That's where you add in your wearable device. That's where you add in the vitamins. That's where you add in other things for those other days. So that was a long answer. The short answer is
really helpful. Yeah.
Short courses of things are fine, but this is where also keeping a headache diary and keeping track and saying, okay, if I notice the frequency starting to go up, I just need to be mindful. Could it be the medication? Maybe, but short periods of time of things. Again, it's about consistency and doing things in the long term that create problems.
I hope that, alleviates some anxiety, because I think that's a big thing for most people with migraine. They feel like they need to limit the medication they use, and they're not sure, right, how quickly this medication overuse happens. So it sounds like at least 3 months, and that, right, it kind of is going to pick up over time.
And it builds. And I also think a big, just to dispel, is I do it too. I think we're all guilty of it. We're like, I don't need to treat because I don't want to waste one of my days. But what tends to happen is by not treating, it develops anyway. And then it snowballs and you wind up having to treat and rescue and actually treat more than you would if you just started at the beginning.
Yeah.
So I think that fear of saying, okay, I like to say, I'm going to pick 3 days a week. Once I go over the 3 days, I have to pick something else, but I'm not going to be afraid. I'm just going to treat at the onset, but then I'll have my other tools and other medications available that won't cause a medication overuse if I have to do more. Because the problems that waiting to treat causes, going into status migrainosis, having increased disability, not being able to participate in life, I feel like are just so magnified by this fear of not being able to treat because you're going to go into medication overuse. And I think that's where seeing your doctor and also keeping track of what you're doing, but not to a point where it becomes overwhelming, but saying, I always write out for patients, medication, this is how many you should use, medication, this is how many you should use. But if you don't, it's okay. Just tell me. Just tell me what you're using, and then I'll tell you how to alter that if necessary. So I think the fear of it can definitely be really anxiety provoking and prevent treatment when treatment is really needed.
Yeah. Oh, such a good point. I would love to know, I know I think you mentioned the seeds for migraine management. So the mnemonic is sleep, exercise, eating, diary, and stress, developed by some great neurologists, and really guides what I do in helping people lifestyle wise work on what's in their control to help manage their migraine symptoms. What would you say is the most important step, or do you start with one of those as like a foundation with your patients?
I usually start with the one that the patient is most open to changing. So for example, if I have a new mom who just has a baby and is not sleeping, I'm not addressing sleep, because you can't, yeah. And I think that for someone who has had chronic insomnia their entire life, that's going to be a much harder egg to crack. So I want to first ask the patient and see what they're more open to changing, because a little change tends to snowball. So I tend to find just first talking about a diary and keeping track of things tends to be the lowest hanging fruit. And then just consistency of eating, just even start eating breakfast. That's it. I think the ones that have the most impactful changes, we know sleep is hugely linked with migraine, and that having poor sleep can propel chronic migraine, can definitely worsen the disease state, but that takes time to correct. And also addressing there's different types of sleep problems. And I think a lot of physicians aren't trained or don't really want to address sleep and insomnia, something that I like to do because I find it so important, but then also talking about appropriate treatments of sleep. So I like to start there with a lot of patients, because once you sleep and give your brain time to actually rest and restore, you're self-healing your own pain signals. So if I had to pick one, if the patient was like, you pick one, you pick for me, I would start with sleep and or exercise, because they propel each other. If you're sleeping better, you'll have more energy to exercise. And if you exercise more, you'll be better able to sleep. But baby steps. And stress, I think, we say it's something we can control, but I actually feel like we cannot control the stress. We can control our reaction to the stress, but stress is omnipresent. It's there all the time for everyone. But I notice I go out and two different people, they can be experiencing the same stressor and react completely differently. So what is it in our own body? It's our autonomic nervous system. It's our sympathetic overdrive that is basically making us respond in a certain way to the stress. So when we talk about stress, it's not eliminating the stress. It's just finding how you should deal with it. So for example, exercise can be a way to deal with stress. Getting better sleep can be a way to deal with stress. So a lot of those pieces build on each other.
Feed into each other. Absolutely. And for folks who are dealing with insomnia or sleep issues and migraine, do you work with them on treatment specifically for sleep, like medication as well? Has that been helpful, or more lifestyle or lifestyle?
Actually, if you look at data, the only proven long-term treatment for insomnia, this is just your bread and butter insomnia, is CBTI, cognitive behavioral therapy for insomnia.
Wow.
So there's lots of medications out there, but actually long-term studies, they don't actually fix sleep. So I liken CBTI to sleep training a baby. If any of you have children, babies, they don't know how to sleep. Their brains we need to train them. We need to train them about their circadian rhythm. We need to tell them when to go to sleep, when to wake up. And what happens with insomnia is your brain is not following your natural cues. Your brain is staying awake when it's not supposed to, waking up during the night. So we basically have to retrain it. How do we do that? It's sleep training. It's basically sleep restrict. There are different programs where you actually restrict sleep, you time lock sleep, and retrain your brain on how to sleep appropriately. There's all different ways to do it with different light sources, light therapies. Melatonin is one where I feel like is way overused and used inappropriately, because it's not a sleep aid, but it can help phase shift or shift people's sleep appropriately. But that is something I really do like to do. It's just, again, it takes time and it takes a structured program. So I also refer in my area, there are some great cognitive behavioral therapists for insomnia. It's a special training. It's not something that every therapist can do. And I found it to be life-changing for a lot of patients. And then I also refer to there's a great online resources as well. There are instructional CBTI courses you can enroll in that actually link back with your doctor. So there's a lot of resources. I just think they're not necessarily well known. It also links into, you have the cognitive aspects of sleep, the behavioral aspects of sleep. So they're multimodal. So also talking about yoga, relaxation, mindfulness, it all kind of comes together. But there is no fix long-term medication-wise. So I will use medications short-term, but I do not personally
Right.
use sleep aids, because what happens is if you don't use a sleep aid, then you can't sleep, because for most of them, the side effect is it makes you tired. And a lot of them that we use for sleep actually prevent your body from going into the correct stages of sleep. So we're using them to make us tired. For example, just give like diphenhydramine, Benadryl. Like I feel like, yes, it makes you tired, but you're not getting restorative sleep. So it's not actually giving your brain the chance to rest. It's just making you sleepy. So I always want to educate my patients on, there are some medications that allow you to go into the right stages of sleep. Absolutely. But sleep is a complex topic, and starting with the lifestyle and the CBTI is the best first step.
That's really good to hear, since insomnia is one of the leading comorbidities with migraine. And there is so much we can do besides take medication that it sounds like even has a greater impact. So that's great to hear. So I got one last question, and then we'll kind of go into some of the comments and questions from the live stream. You said in your Migraine World Summit interview, I think food and food triggers are the most talked about thing in migraine with the least amount of evidence. And I would love for you to elaborate on that.
I feel like if I hear one more news story being like, what are the top 5 food triggers for migraine? How to eliminate foods. So the data for food triggers is so poor. Actually, a lot of times what people think are food triggers are actually prodromal symptoms. It's actually food, like for chocolate, like it's actually like you're craving, you eat chocolate, but it's actually part of the actual migraine phase, the beginning of a migraine attack. And there are certain populations of people who food will have an impact. For example, celiac disease. So gluten. If you have celiac disease, yes, you're going to be sensitive to gluten. But everything else out there, it's so specific for the person, and the impact that it has, I think, positively is positive for so few people, but the stress it creates and the disordered eating it creates is such a negative that I personally don't feel they necessarily even out. So I believe in healthy eating and clean eating. And I think for life in general, it's good. We want to have anti-inflammatory foods, but instead of focusing on cutting things out, I really feel, and evidence has shown, why don't we focus on including the good things? So we know processed food isn't good. We know that things with like the common things like nitrites added to deli meats, like that's not natural. So instead of saying this is what's triggering me, let's just take out the bad and increase the good. And I just have found that focusing on the food, I want to say it gives great outcomes. I personally haven't seen it. I'm sure there are some people out there who do, but then also, what does it mean that a food triggered you? What does that mean? Does it mean I ate the food 5 minutes ago? Does it mean I ate it 24 hours ago? What does it mean? And there's really no great definitions there. So in someone who has very low frequency migraine, maybe you can track something, but think about the people, especially patients I see, they have chronic migraine. It's impossible. Like, how do you figure out what? And then I have one patient who resorted only to eating broccoli and rice. And because felt that everything was contributing, I had to convince her, I'm like, we have to add things back in. Even if you have it, take it in and feel like it's contributing, you have migraine every day. So we don't know. But actually she had a dietary deficiency from cutting everything out. So actually that was contributing to it. So again, like there are different people, diet can have a role, but I think my main takeaway is that it seems to be all we talk about in the media with migraine, when it shouldn't. It makes it seem like it's something you're doing, right? Like if only you stopped eating that, if only you drank more water, if only you did this. But the data for food triggers, if I could go back through the evidence, is just really, really poor. So my takeaway point from that is that if you're a person who finds that every single time you eat something, eliminate it from your diet for 8 weeks, keep a diary and see if not eating it makes a difference. If it does, okay, you can then reintroduce and see if it triggers, but otherwise focus on eating real food from the earth without additives, and you'll eliminate most of those triggers anyway if they were there.
Yeah. Oh, great point. And also you just bring up the point that I think it's easy for folks with migraine to kind of see, triggers as this like 1-to-1 ratio, like I did this or I was exposed to this and then migraine happened. And it's often not that clear. And there's right, this is a neurological disorder, and it's impossible to pinpoint. I think a lot of neurologists, which I'm glad about, are kind of moving away from just this trigger avoidance and more just like you, how can we create healthy habits and structure to our lives that are just calming our nervous system overall, raising our, migraine thresholds, so we can just be more resilient and not just like whack-a-mole triggers, and just avoid life instead of feeling like we can live more freely in the world.
I also liken it to, migraine is a disease, but other diseases, high blood pressure, for example. Like, are you going to say that every time you like go and you're at a scary movie and your blood pressure rises, is that was the trigger? So I'm going to avoid movies, or the diabetic who maybe it wasn't that they wanted to eat a piece of cake, but maybe it wasn't that one piece of cake. Maybe it was the piece of cake and then they had something else and that spiked their blood sugar. So maybe it's not always that one-to-one, and it's not always the one thing. And we know for migraine, most of the time, it's not one thing. You could look at the analogy of the cup that runs over, like you fill things up and only when you add that last thing in, does it spill. I tend to use the cliff analogy that like, there's a cliff, you get close to it, maybe like it's raining and maybe like you're a little bit stressed and then you ate something and then that pushed you over the edge. So taking things in isolation that one trigger did it and then focusing and trying to eliminate it. Yeah, it's the whole trigger identification elimination. I'm glad has been gaining less favor over time.
Yeah. And right. And it's easy mentally to see that. And, okay, we avoid this trigger, we take this medication. And I think what your approach is leaning towards is that, no, it is more of a systemic, like in terms of your lifestyle, what are all the healthy pieces that we can put in place? What are the medications, devices we can layer on? But it does, it can feel a little more complicated to do that. It's not a quick fix. It's not a one-to-one thing. It is multiple things, right? Working on migraine. But in my experience, I also feel like that's the way to go. And it really can make a big difference so that people aren't feeling that they just have to limit everything and have these side effects that aren't working for them.
I know it sounds overwhelming. Doing a lot of little things sounds overwhelming, but it's actually, I think it's liberating personally, because I feel like when you feel limited and you feel restricted, you feel like you're like in a box, that sucks. And I feel like when you think like, I can't go out and I want to go out and have a drink with my friends, but I know alcohol triggers me. But at the same time, I tell my patients, maybe, but who knows in that instance? So let's just make sure we're doing everything else we can. So you basically had a good dinner and you drank a lot of water and you got a good night's sleep. Most of the time they go out and they have alcohol, it's okay. And also it's okay to do things that trigger you. Yes, it might suck in the moment, but if we have a good plan in place, then we will get through it and we should enjoy things instead of always constantly worrying that it's going to trigger. I just have so many patients who have missed out on so much of their life because of it. So yes, it's overwhelming to think you need all these little pieces, but to me, it's more overwhelming to think that you're going to miss out on so much of life without incorporating them.
100% agree. Do you have 5 more minutes to go through like these final little questions?
Yes, I'd be happy to. I love talking about everything.
I know. I think we're just gonna have to bring you back because I got like a whole ream of additional questions, but this has just been so good. Okay. We got a question from Rissy about starting to increase her working out capacity. She worked with me and now is able to do yoga more regularly, but like wants to, get back to maybe doing weights or running. And how do you get people, perhaps from that chronic migraine state where any exercise just feels like it triggers migraine, or, they're just exhausted, they don't have energy?
So I like to use the subthreshold exercise approach, which is actually something that was developed for dysautonomia. So for like POTS, postural orthostatic tachycardia syndrome, which is basically small stepwise approaches to exercise to build up tolerance. So I base my programs off of that, where it is trying to target small gradual increases. So there's some programs out there that people can Google and look at, but it first starts exercises in a recumbent position. So something that's non-weight bearing, starting with bands for stretching, 5 minutes, like literally 5 minutes, but every day doing some part of the program. So like you'll do a little bit of resistance, and then you'll do maybe some bridges, like stationary bridges on the floor. You'll do some light crunches, and then escalating up more gradually to an upright position. So exercise, I would never just go to running. Like running is pounding. Like by definition, migraine is worsened by physical exercise exertion, mostly running and jumping. So yeah, we got to build up there. But we want to be pushing our heart rates to elevate without causing pain. So 2 ways to do it. First is by going exercises that are recumbent, strength based, and integrating cardio. So going to rowing. So rowing is a really good recumbent kind of exercise, then going to a recumbent bike, then going to things like swimming, then going to things like elliptical, and going to like a faster walking, running. But it's not just going from 0 to running. So I would say doing the lowest impact exercises, and then in shorter periods of time. So every person has a different amount of time or a heart rate where they'll have a symptom triggered. So you can go either way. You can say, okay, I'm going to start with 5 minutes. I'm okay. So I'm going to start with 5 minutes. I'm going to do 5 minutes 3 times a week for 2 weeks. And then I'm going to go to 6 minutes. It's like a very slow progress. I'm going to go to 6 minutes of rowing. And then once you're able to do, we can make what adequate is for based on the individual person. Then we might progress. Okay, we did rowing. Now let's go to stationary bike and progress from there. It's obviously a slow process, but it's also getting our body to tolerate it. Another way I do it is looking at heart rates and then rates of perceived exertion. So actually everyone has a target heart rate in different heart rate zones that you can work in. So actually calculating that for each person, you could look at your, like basically your low, medium, and then like high heart rate, and getting your heart rate just to the border of each zone with the exercise, and then stopping. And then doing that, basically it's the sub threshold, getting it right to the edge without falling over, and over time pushing that. So if I want my heart rate to be 120, I'm going to get it to 120 comfortably for X amount of time. Then I'm going to push it to 125 for maybe a minute and then back off. But that's how I like to prescribe exercise programs. And there are ways that I calculate the different numbers for patients. And actually I'm a great physical therapist who works with this too, that I tend to work with locally, but it's nothing that you can Google and like find online. It's actually putting a lot of different data together. But I do think if there was any exercise program to follow, looking at the POTS exercise programs are probably some of the best places to start, because they're gradual, they're gentle, and they put together a lot of what I talked about.
Great suggestions. Thank you. Let's see here. Yeah, I think a lot of folks get to that point where perhaps their own neurologist kind of tells them there's nothing more they can do, right? Maybe the CGRPs that haven't worked for Dodie, she mentioned. She's still having, chronic migraine symptoms. So, I know everything's very specific for individuals, but yeah, I think, what would you say to folks who feel like, their neurologists are kind of don't know what to do with them anymore?
First of all, I'm saying I'm sorry that you're experiencing that. And I think that medicine, unfortunately, there's so much we don't know. And when doctors and when anyone doesn't know anything, it's like there's nothing else we can do, right? But I have to say there's nothing else that person can do. It's out of their realm of knowledge. Doesn't mean there's nothing else to do. It's just we have to look to other avenues. And I get a lot of patients who there's nothing else we can do. We have to find other ways. And like I said, everyone's receptor profile is different. And because that one neurologist hasn't found it, doesn't mean it can't be found. And like, I wish there was that everyone had access to a headache specialist. If I could make a program, which one of my life dreams, just to make a program to teach how to do it basically yourself and figure this out. But it is a process of figuring out and finding the right person to figure it out with. So I would first say making a list of everything that you've been on, and saying, how long was I on it for? So I think a lot of times we're on things for short periods of time. Any migraine medication, at least 3 to 4 months at an adequate dose to become effective. And also effective means different things for different people. Even if you had 30 days, headache a month, and went to 28, doesn't seem like a big difference, but actually you add the 2 days there, you take something else and you reduce it by 4 days, it's additive. So it's not that all or nothing, it worked or it didn't work. What was the improvement? And basically if you go to see someone else, having that all out there and saying, this is what I've tried. These are the doses that I've tried. And what have I tried together versus separate is actually enlightening. Like, that's what I really like to see. And I look back and someone comes, I actually have an intake form that literally is 26 pages of like every medication that someone could have tried. And they're astonished to say, wait, there's so many more out there that I didn't even know about. And I get excited when a patient says, I've tried everything. And then they're like, well, I tried it for 2 days, or I did it this way. I'm like, actually, you've tried nothing. Like, you have been on it, but you haven't actually given it adequate trials and in combinations. So for the person with the question, I believe that there's something out there that hasn't been tried and hasn't been found. It's just taking the steps to find someone to figure it out with you. But don't give up.
Yes,
Get there.
Okay, swear. Last question. I work a lot with my clients with pain reprocessing therapy for folks who perhaps know the Curable app or the book The Way Out by Alan Gordon, right? We're kind of this question, is migraine a result of neuroplastic pain in which it's not a structural issue that's causing it? Is it contributing? Do you have what's your take on migraine and neuroplastic pain? Or if you know that terminology,
Yes,
by other names.
Because I think it's one of those things where just because something you can't see on an image or something that isn't a structural issue, doesn't mean it's still not a functional issue. So neurotransmitters you can't see them. They're happening, but you can't see it is a dysfunction. It's a dysfunction of appropriate nerve processing. Actually, if we look at genetic studies, there are genetic mutations and genetic polymorphisms that actually predispose people to migraine. There are actually parts in the brain when you do PET scans and actually do functional studies, not looking for structure, that actually show changes. So it is in most times an inherited condition that is an improper processing of pain signals due to neurotransmitter and other chemical dysfunction. So yes, you can be predisposed to migraine and not actually develop clinical symptoms. And I think that's where people come into play. Is this something that's structural? Is it something not? But it is a disease. It's a disease that's inherited. And then, like everything, there's always an environmental and a person component. And I think that just always knowing that it's an inherited disease. If you were born with type 1 diabetes, if you were born with another inherited disease, like we wouldn't be having the same conversations.
Yeah. And right. So it's something that, it's a legitimate thing. We're not making this up. And, from that biopsychosocial model, pain is all affected by, it's not just you have it or you don't, right? Like your environment, like you said, your temperament, what you
can be modulated. And I think that's the benefit of it. Like you were saying, because you do pain reprocessing, just because you're born with like an appropriate, like a dysfunction of pain modulation, we can teach ourselves also to some degree. Obviously we can't cure, but we can retrain our brains. We know we can grow synapses. We can actually reprocess and restructure our brains by doing the hard work of neurofeedback, biofeedback, like all pain reprocessing. And by teaching our brains how to interpret pain signals differently, we actually are changing our underlying biochemistry. So if that was part of the question, it is, yes, it is inherited, but we can change it. But actually doing it, I think is a hard process.
Right. Well, Dr. Natbony, where can people find out and work with you? Do you work with people out of state, telehealth? Tell us how that all works.
I do. You can find out everything about me on my website. It's integrativeheadacheny.com.
Post that in the comments now.
Also, you can also reach it just by Googling my name to come up. And there's basically all about me. If you have any questions for appointments, email is info@I for integrative, H for headache, M for medicine, N for new, and Y for York.com. So ihmmy.com. You can also follow me on social media. It's just at Lauren Natbony, MD. And yeah, I love talking all things migraine, all things headaches. So please reach out.
And you work with folks all over the United States?
So telemedicine laws dictate where the patient has to be, but I do have licenses in multiple different states. I also work with doctors in other states. So let's say it's a second opinion, and let's say that that could always be done. And then I have patients from Alaska, I have patients from Hawaii, I have patients who I will see maybe once in person or see remotely, and then work with their doctors and be available for consult.
Oh my goodness. Well, I hope you guys are all inspired by everything Dr. Natbony said about how we can, live better with migraine, whether it's combining treatment and lifestyle strategies, and that it's not to give up, that there's always something more we can try in combination. It's never just one thing. And so thank you so much for your time and expertise, especially going over a little bit in our time.
I could talk forever. I feel like if you get to, it's just sort of like, it's my passion. I feel like I love what I do. I'm lucky in that sense. So I feel like I really enjoyed it. So thank you. Thank you for having me. Thank you for everyone that tuned in. Hopefully it was helpful for a lot of people.
Of course, yes, and we might just have to have you back and answer a whole new
anytime. I would love
questions. All right, I'm going to end the live stream. Thank you, everybody.
Thank you.